Hello and welcome to this presentation titled Providing Inclusive Care for LGBTQ+ Patients with Opioid Use Disorder. This is one presentation in a series of webinars from OPA aimed at supporting pharmacists to provide the best care possible to patients receiving opioid agonist therapy. So I'm James Morrison. I'm a community pharmacist with more than 10 years experience, and I have no past relationships with commercial entities. I have received a speaker's fee from OPA to prepare and present this webinar. And we wish to thank the Ministry of Health and Long-Term Care for providing the funding required to support this program. I'd like to review the learning objectives. We're going to begin with contrasting the prevalence of substance use disorder between the LGBTQ+ population and the broader population. Then we will determine contributing factors to the greater prevalence of opioid use disorder in LGBTQ+ individuals. Then we will identify high-risk sexual and injection drug behaviors associated with non-medical use of opioids by LGBTQ+ individuals. Then we will discuss harm reduction approaches that pharmacists could implement to support LGBTQ+ patients with opioid use disorder. And lastly, we will reflect on the role of the pharmacist in providing care to LGBTQ+ patients. So you might ask, why do pharmacists need to build cultural competency with regard to providing care for LGBTQ+ patients? Well, there's 50% of LGBTQ+ patients in certain surveys have reported that they were seeing providers who were unable to address their unique needs, and that was due to a lack of relevant knowledge. So it's related to the competency of the practitioner. And this has been identified historically that there's a gap in education with regards to the needs of the LGBTQ+ patient population in healthcare disciplines. And the push to develop cultural competence with regard to providing care to this patient population has been emerging across healthcare disciplines when we're educating providers. I'd like to begin with discussing the meaning of the acronym LGBTQ+. There are variations on this acronym used throughout different agencies. L means lesbian, which refers to a woman who is attracted to another woman. G is for gay, which refers to someone who is attracted to others of their own sex. The term is often used to describe men who are attracted to other men. The B is for bisexual, which refers to people who experience sexual and/or emotional attraction to more than one gender. T is for transgender, which refers to a person whose gender identity does not match the one they were assigned at birth. These individuals experience an incongruence between their gender assigned at birth and their inner sense of gender. In contrast, cisgender, which is not part of this acronym, refers to someone who exclusively identifies as their sex assigned at birth. So cisgender would be someone who was born biologically male and identifies as male gender identity. Q is for queer, which is an umbrella term for sexual and gender minorities that are not heterosexual or cisgender. Queer was originally used derogatorily against those with same-sex desires, but beginning in the late 1980s, queer scholars and activists began to reclaim the word. Another acronym I often use is LGBT2SQ, which is the one used by Rainbow Health Ontario, a leading organization in the care of gender minorities in Ontario. And in that acronym, the 2S, it refers to two-spirited individuals. And these are people who identify as having both masculine and feminine spirit. And it's a term that's been used by Aboriginal people to describe sexual, gender, and or spiritual identity. Another important term that is used at times instead of LGBTQ+ is sexual minority. This refers to individuals that differ from the majority of surrounding society in sexual identity, orientation, or practices. Most often, it refers to lesbian, gay, bisexual, and transgender people. There are various tools available to visually help practitioners and individuals distinguish between concepts of gender identity, gender expression, sex, and attraction, all of which exist on a spectrum. One of these tools is the gender unicorn, which is on the slide, and another is the gender-bread person, so similar idea. Gender identity is one's own internal sense of gender or awareness. It is often described as a feeling of manness or womanness. Gender identity is not necessarily binary, and some individuals may use other terms aside from male or female, such as androgynous, third-gendered, or other terms. Some people assign male or female at birth may express different gender identities later in life, which is called transgender. For others, their gender identity is consistent with their biologic sex, and we discussed that is also cisgender. So it's either transgender or cisgender. Some trans people who choose to address the incongruity between their bodies and internal sense of gender, they may take medication therapies, for example, feminizing or masculinizing hormones, and some may choose to have surgery to address the incongruence, while others do not. The term assigned sex is used instead of just sex because doctors make a determination of a baby to be either male or female, even though the reality is not always that definite. Intersex refers to people who have chromosomes, hormonal profiles, or genitals that are not typically male or female. Historically, intersex babies have been operated on and or assigned one of the two binary sexes at birth. Gender expression is the outwardly expression of gender. This can include behavior and physical appearance such as clothing, hairstyle, makeup, body language, and voice. A person's chosen name and pronoun are also common ways of expressing gender. Gender expression may not always match gender identity. For example, an individual identifying as female may dress in traditionally masculine attire. Some may identify as neither man nor woman, thereby incorporating both feminine and masculine elements in how they present themselves. Sexual orientation. Sexual orientation refers to a person's emotional and or sexual attraction to others. Some common terms used today include heterosexual or straight for those attracted to a different gender. We have already discussed the terms lesbian, gay, and bisexual. Someone who is attracted to all genders may identify as pansexual. This is not an exhaustive list of orientations. I'd like to talk about stigma and discrimination. The lives of sexual minorities are often afflicted by stigma as well as discrimination. Stigma is a negative stereotype that may lead to discrimination. Discrimination is unfair treatment due to a person's identity, including sex, sexual orientation, gender identity, and gender expression, among other things. Under the Ontario Human Rights Code, every person has a right to equal treatment with respect to services, goods, and facilities without discrimination due to the identities listed above. Stigma is the negative stereotype, and discrimination is the behavior that results from this negative stereotype. We really need to consider stigma when we're addressing opioid use disorder among LGBTQ+ populations. Research indicates that LGBTQ people use some substances such as tobacco, alcohol, and other drugs at a rate that is 2 to 4 times that of the broader population. LGBTQ substance use must be understood in the context of stigma, prejudice, and discrimination to which LGBTQ people are often exposed. Beginning at a young age, LGBTQ people may experience frequent discrimination, marginalization, and victimization due to their sexual and gender minority statuses. The stress caused by high levels of external stigma can affect coping skills, emotions, and the achievement of positive interpersonal relationships. At times, stigma can become internalized and lead to concealment of true self, self-hate, feelings of worthlessness, and fear of rejection. The Center for Addiction and Mental Health, CAMH, has identified that isolation, alienation, and discrimination from a homophobic society as stressful, and that is one of the main reasons LGBTQ people use substances, is to escape from these feelings. Some LGBTQ people may turn to substances such as opioids for euphoria or relief. These coping mechanisms can lead to other complications such as physiologic dependence and addiction, mental health disorders such as depression, and bloodborne illnesses due to needle sharing. Some individuals may face stigma for identifying as a sexual minority and then face additional stigma due to substance use disorder, which then creates additional barriers to accessing the treatment required and continuing in treatment. While rates of drug use among LGBTQ+ people are higher than within the general population, just like the general population, the majority of LGBTQ+ people do not use substances. There are a number of theories as to why LGBTQ+ community experiences a greater burden of substance use disorders, and this list is not exhaustive. While being LGBTQ is not a cause of substance use, and the use of substances is not always related to an individual's LGBTQ+ identity, some of the reasons for substance use in the LGBTQ+ population are the same as the general population, but it is important to recognize that there are some specific reasons that LGBTQ+ people have higher rates of substance use. For example, a lack of non-bar space. Historically, there have been limited social environments for LGBTQ+ people aside from bars or parties. At times, it may have been unsafe to socialize in public space due to discrimination. This resulted in some LGBTQ+ people's association of socializing with the use of alcohol and other drugs. Furthermore, individuals may have developed a peer set that also uses substances regularly. Cultural acceptance. The use of some substances may be accepted within LGBTQ+ communities or may be considered a part of cultural life, signifying or confirming personal identity and group belonging. A Toronto study of racial minority gay and bisexual men who attended parties and clubs reported feeling pressured or obligated to use drugs when their friends were using them. History of criminalization. Until 1969, homosexuality was illegal in Canada, and LGBTQ+ people experienced repression by police. Consequently, the fact that a substance may be illegal may not indicate the same level of risk as viewed by the general population. LGBTQ plus people have learned experience that not everything that is illegal is necessarily wrong. Coping with stigma. We already discussed this a little, but some LGBTQ people may use substances to cope with the stress of coming out, rejection from family and friends, discrimination, harassment, and feelings of self-loathing. Stigma persists throughout the lifespan of LGBTQ plus people, and they may not exhibit a decrease in substance use with age that is seen in the general population. Coping with trauma. Various traumas have been found to be associated with the use of substances in LGBTQ plus people in American studies. Traumas included violence, threats, or fear of being unsafe, stress related to living with HIV, relationship stress, financial problems, sex work, and discrimination. Self-medicating. Some LGBTQ plus people use substances to reduce the effect of health problems, thereby self-medicating. The use of cannabis has been associated with anxiety and mood disorder, but the directionality is unclear whether cannabis increases anxiety or whether anxiety brought individuals to use cannabis. Others may use substances to alleviate pain. In a study of British Columbia students, it was found that lesbian, gay, and bisexual youth were found to use substances to lessen anxieties about having sex. Lastly, recreation. The Addiction Research Foundation of Canada noted that some substances may be used to enhance sexual pleasure or facilitate socializing for some individuals. Substance use may have a greater perceived benefit that outweighs the perceived risk of use. It's been said that prevention efforts to reduce substance use in the LGBTQ plus population must address some of these root causes of substance use in the population in order to be successful. Knowledge check question number 1. LGBTQ plus youth are blank times more likely than the general population to misuse prescription opioids. And we have A 2 times, B 3 times, C 4 times, D 5 times.